Discuss fetal growth test. Good morning, everyone. Today we will discuss fetal growth restriction and little bit about oligohydramnios. So we will discuss small for gestation age fetuses and about fetal growth restriction. By definition, fetal growth restriction is fetuses with an estimated fetal weight less than 10 percentile for gestation age and small for gestation age involves whose growth rate is less than 10 percentile for gestation age according to IUGR 2019. So what is fetal growth restriction? It involves neurological restriction of this genital growth condition and growth restricted is small fetuses with recognizable pathology and molecular studies. And its likelihood of IUGR is higher in severe small gestation infants. So, what is it about fetal growth restriction? Because there is risk of sudden IUD is increased 5 to 6-fold, and there is a risk of IUGR in 50% of unexplained IUDs. And there is risk of cumulative death for SGO 3 6 week and 1 to 1 for week. Incidence of fetal growth restriction mainly in Asia, 75% of all affected infants, and in India, prevalence of low birth weight is 26%. So, during antenatal period, fetal weight gain is up to 15 week, there is 5 gram per day. 24 week, there is 15 to 20 gram per day. 34 week, 30 to 35 gram per day. And there are 3 phases. First, 16 week, initial phase of hyperplasia, rapid increase in cell number, and 16 to 32 week gestation, there is cellular hyperplasia and hypertrophy, and after 32 week, mainly there is hypertrophy. So, physiology of fetal growth. This is a complex interplay of various factors like maternal, genetic, placental, nutritional, environmental, and hormonal. Etiology and risk factors are in fetal, there are chromosomal trisomy 21, trisomy 18, trisomy 13, some genetic syndromes, Russell-Silver syndrome, and intrauterine infection like CMV infection, Toxoplasma gondii infection, rubella, malaria, and varicella. In maternal, there are several maternal conditions like chronic hypertension, preeclampsia, abruptio placenta, pregestation diabetes mellitus, chronic lung renal disease, cyanotic heart disease, thrombophilias, hyperhomocystinemia, sickle cell disease, uterine malformations, alcohol and cigarette smoking, and drug abuse, heroin and cocaine. Uteroplacental are ischemic placental disease, abnormal placentation, structural anomalies of placenta, succulent lobe, filamentous insertion of cord, and single umbilical artery. Others are ART, short interconception period, extreme of maternal age, low pre-pregnancy weight, and poor nutritional state. So, etiology of fetal growth restriction is combination of maternal fetus and placenta. In maternal, only in maternal there is poor gestation weight gain, constitutionally small mother, poor nutrition and social deprivation, and there are eating disorders. And drug and teratogens both will affect in maternal and fetus both. Only in fetus there are fetal malformation, and fetal and placenta there are genetic abnormalities or multifetal gestation, and placental and maternal medical disorders, and placenta or cord abnormalities. And all 3 will be affected in infections. So, classification of FGR. There are 2 types of fetal growth restriction, early onset and late onset. In early onset fetal growth restriction, placental disease is severe, uterine artery Doppler, umbilical artery Doppler abnormal, high association with preeclampsia, mild uterine artery Doppler normal, low association with preeclampsia in late onset FGR. Hypoxia, in early onset there is severe, and in late onset mild. Mortality and morbidity is high in early onset and Late onset, lower but common cause of late stillbirth and poor long-term outcome. Prevalence is low, early onset 1 to 3%, high in late onset 3 to 5% problem we can manage, and in late onset diagnosis. This is pathophysiology showing in pregnancy in normal pregnancy there is spiral artery in myometrium and trophoblast giant cell, extravillous trophoblast, and this is decidua and placental villus and mesenteric trophoblast layer. And there is low pressure in this spiral artery, so high blood flow. But in pregnancy with fetal growth restriction, there is high pressure in the spiral arteries and there is reduced blood flow. So in normal, increased vascular capacitance and increased flow to uterus and placental tissue, low resistance, high flow system. In IUGR, trophoblastic invasion is confined to the decidual portion of myometrium and there is high resistance and low flow system. So early onset versus late onset FGR. In early onset FGR, there is reduction of villus surface area and impaired trophoblastic invasion leads to increased umbilical artery impedance. This leads to hypoxia and ductus venosus abnormality and leads to increased morbidity and mortalities. In late onset FGR, there is impaired villus maturation. This leads to umbilical artery impedance often not impaired and impaired nutrient and gaseous exchange, and this leads to impaired MCA Doppler and CPR cerebroplacental ratio and increased morbidity and mortality. So diagnosis of FGR by maternal history, accurate dating for period of gestation, clinical examination, and at last by ultrasound and Doppler. So history is most important part in this for the diagnosis of fetal growth restriction. Like this. This table, according to RCOG 2013, this table shows maternal age more than 40 years leads to birth weight less than 10 percentile. And exposure to smoking and cocaine also leads to birth weight less than 10 percentile. And this also shows, this table shows previous history of small gestation age, previous history of stillbirth, previous preeclampsia, pregnancy interval, SGA, maternal medical history, hypertension, diabetes, renal disease, and antiphospholipid syndrome all will affect to the birth weight of baby. And current pregnancy complication in development like threatened miscarriage, ultrasound appearance, preeclampsia, pregnancy-induced hypertension, placental abruption, unexplained APH, weight gain, exposure, and double dual screen marker all will affect the fetal birth weight. And accurate dating. So for accurate dating, guidelines for redating based on ultrasound, these guidelines shows how to calculate the dating according to LMP and by ultrasound. By clinical examination, first is fundal height. This is screening method, but sensitivity is less than 35% and specificity is less than 90%. And between 18 to 30 week gestation, in centimeter, it corresponds to gestation age plus minus 2 weeks. Expected fetal weight based on fundal height is calculating using Johnson's formula, that is fetal heart minus 12 if head is not engaged, multiply 155 fetal heart. Fundal height, fundal height minus 11 if head is engaged, multiply 155. Clinical examination by abdominal girth. After 30 weeks, it will increase by 1 inch per week. Symphysis fundal height, serial measure of symphysis fundal height recommended at each antenatal visit from 24 weeks, as this improves prediction of a SGA neonate. So direct measurement of symphysis fundal height detects only 30% of IUGR. This picture shows fundal height is measured in centimeter from the symphysis, pubic symphysis to the topmost portion of the uterus, but drawback of this graphical representation is imprecision. So, by ultrasound, Abdominal circumference is the single best measurement for the detection of IUGR. It is related to the liver size and it reflects the fetal glycogen storage. Fetal abdominal circumference or estimated fetal weight less than 10 percentile can be used to diagnose a SGA fetus, and both abdominal circumference or estimated fetal weight to estimate growth velocity, they should be at least 3 weeks apart to minimize false positive result for diagnosing fetal growth restriction. Fetal biometry. Mean growth rates for abdominal circumference and estimated fetal weight after 30 weeks of gestation, 10 mm per 14 days and 200 gram per 14 days. And changes in abdominal circumference less than 5 mm over 14 days suggestive of fetal growth restriction. So, something about Doppler, uterine Doppler and fetal Doppler. So, uterine artery Doppler in first trimester, in early second trimester and in late third trimester, normal impedance to flow in the uterine artery. So, abnormal uterine Doppler, normal uterine Doppler is normal impedance to flow in the uterine arteries with characteristic waveform of early diastolic notching. Increased impedance to flow in the uterine artery with the characteristic waveform of early diastolic notching and very high resistance to flow in the uterine artery with reverse diastolic flow. Uterine Doppler. Uterine artery Doppler can be abnormal in the presence of abnormal umbilical artery Doppler and can predict poor outcome. Uterine artery Doppler at 20 to 24 week moderate predictive value for severely small for gestation age neonate. So, woman with abnormal uterine artery Doppler at 20 to 24 week, more than 95 percentile and or notching. So, serial ultrasound measurement of fetal size and assessment of well-being with umbilical artery Doppler commencing at 26 to 28 week. Early Doppler changes detected in peripheral vessels such as umbilical artery and middle cerebral artery. Late Doppler changes can be detected in abdominal flow in ductus venosus and fetal aortic and pulmonary outflow tract. Predictor of poor outcome, in addition to the of umbilical artery Doppler, cerebral-placental ratio, uterine artery Doppler, estimated fetal weight less than 3 percentile, irrespective of CPR and uterine artery Doppler. So, definition of FGR should include these 3 parameters in addition of umbilical artery Doppler. So, umbilical artery Doppler, it is direct reflection of a placental flow, and in umbilical artery, at 3 sites, we have to measure Doppler, placental origin, fetal abdominal insertion site, and middle of the free-floating vessel. Resistance at abdominal insertion site is higher and progressively decreased toward placental site, and it is strong predictor of adverse perinatal outcome, sensitivity 79% and specificity 93%. Umbilical artery Doppler, abnormal Doppler plus estimated fetal weight less than 3rd percentile is strongly associated with poor obstetrical outcome. Middle cerebral artery Doppler. If continued and progressive fetal hypoxia, a phenomena is brain sparing effect. In this, dilation of cerebral vessel to increase blood flow to brain at the expenses of other organs, and Doppler study depict it as increase in diastolic flow with increased PI. Presence of such compensation lead to compromised fetus in utero. Cerebral-placental ratio, test individual candidate CPR is MCA PI upon umbilical artery PI. Ratio correlate better with adverse outcome as compared to individual component and used for diagnosis of FGR. So, cerebral-placental ratio is middle cerebral artery PI divided by umbilical artery PI. Although SD ratio, RI and PI have been reported when computed CPR, more recently PI is the computation of the choice and improves the sensitivity of umbilical artery and MCA alone, as increased placental impedance of umbilical artery is often combined with reduced cerebral resistance of MCA. CPR can be decreased even when its individual components are still within normal range. Little bit about ductus venosus Doppler, strongest single Doppler parameter to predict short-term risk of fetal death in early onset FGR. Abnormal in advanced stages of fetal compromise. Absent reverse wave during atrial contraction, risk of perinatal mortality 40 to 100% irrespective of gestation age. Sufficient to recommend delivery at any gestation age after steroid cover. So absent or reverse flow during atrial systole in the diastolic DV ductus venosus suggests a high risk of fetal death within 1 week, and reverse A wave for more than 7 days predict stillbirth with 100% sensitivity and 80% specificity. So FGR early versus late. Early onset FGR is 20 to 30% and most often is associated with preeclampsia in 50% cases. And there is severe placental insufficiency, chronic fetal hypoxia, abnormal uterine artery PI, ductus venous pulsation, and management is challenging. Late onset FGR is 72% cases. Preeclampsia association is 10%, placental insufficiency is mild, and uterine artery Doppler might be abnormal, DV abnormal remote. Intrapartum fetal distress and neonatal acidosis, there are high chances and management not challenging. Both associated with poor neonatal outcome from neurodevelopmental, cardiovascular, and metabolic standpoints. Complication in antepartum period, there are chances of stillbirth, iatrogenic maturity, and abruption. During intrapartum, abnormal fetal heart racing, asphyxia, need for emergency cesarean, need for neonatal resuscitation. Neonatal period, there are chances of hypothermia, hypoglycemia, hypocalcemia, polycythemia because of premature baby or small for gestation baby, sepsis, respiratory distress syndrome, IVH, necrotizing enterocolitis, coagulopathy, hepatocellular dysfunction, and hypoxic ischemic encephalopathy. So, decision algorithm for FGR babies diagnosis by ultrasound, estimated fetal weight less than 10 percentile, exclude congenital anomalies, karyotyping abnormalities, and congenital infection. Treatment, it includes rest in lateral position, increased fluid intake, and stop smoking. Fetal surveillance, fetal cake count, serial growth scans, biophysical profile testing, and Doppler velocimetry. Karyotype should be offered in severely small fetuses with structural anomalies and in those detected before 23 weeks of gestation, especially if uterine artery Doppler is normal. Serological screening for congenital cytomegalovirus and toxoplasmosis infection should be offered in severely small fetuses, and testing for syphilis and malaria should be considered in high-risk population. So in early onset FGR, there is placental disease and increased impedance, hypoxia, centralization. Advanced hypoxia and acidosis lead to reduced cardiac compliance, and serious injuries lead to death. So loss of short-term variability on CTG. Late onset mild FGR, placental disease, reduced placental reserve, hypoxia, centralization, acidosis, injury lead to death. Fetal heart rate monitoring. On conventional CTG, 40 to 50% false positive rates. And in computerized CTG, loss of short-term variability of fetal heart rate, better prediction than acceleration, deceleration, impending sign, and preceded by AB or reverse diastolic ductus venosus pulsation. Other methods, serial ultrasound evaluation of fetal growth, impedance to blood flow in fetal arterial and venous vessels, and biophysical profile. Best approach consists of longitudinal surveillance starting with integrated fetal asset testing, multi-vessel Doppler examination, fetal heart rate analysis, and assessment of fetal activity through biophysical profile. Because the combination of tests improve the prediction of acidemia and stillbirth compared with single tests. Severe observational studies support integration of biophysical profile and Doppler parameter in preterm IUGR. So in early onset IUGR, elevated umbilical artery Doppler PI, No other abnormality, every 2-week Doppler and weekly biophysical profile. Low MCAPI or CPR, weekly Doppler plus biophysical profile. Umbilical artery absent and diastolic velocity, consider admission, 2 times per week Doppler and biophysical profile. Umbilical artery reverse and diastolic velocity and increased ductus venosus Doppler indices and or oligohydramnios. Admission 3 times per week Doppler, biophysical profile and daily CTG. Absent reverse DVA wave admission, daily Doppler, biophysical profile and prepare for delivery. In late onset IUGR more than 32 week, elevated umbilical artery Doppler, PI, no other abnormality, weekly Doppler and BPP. Low MCA, PI or CPR 2 to 3 times per week Doppler plus BPP. So what will be the timing of delivery for these fetuses? Depends on maternal condition, fetal condition and gestation age. So stage-wise management of fetal growth restriction. Severe 1, 2, 3 stages. Severe smallness or mild placental insufficiency. These criteria, if present in weekly monitoring and the mode of delivery, at 37 week we have to induce, and mode of delivery can be vaginal delivery also. In severe placental insufficiency, uterine artery, umbilical artery, ADV, reverse AOI, bi-weekly monitoring, and at 34 week we have to go for cesarean section. Low suspicion, fetal acidosis, uterine artery, umbilical artery, RADV, reverse and diastolic flow. Monitoring 1 to 2 days, and if at 30 weeks, cesarean section. High suspicion, ductus venosus, reverse flow, fetal heart rate deceleration, 12-hour monitoring, and at 26 week plus minus, we have to go for cesarean section. So biophysical profile, fetal tone, respiratory movement, gross body movement, AFI and conventional CTG, these include biophysical profile. False positive rate is 40 to 50%, false negative rate is 0.8 per 1000 delivery. Amniotic fluid index, oligohydramnios, AFI less than 5, not an acute marker in presence of Doppler indices. Its role in management protocol of FGR babies is questionable. Prevention, optimization of maternal medical condition, behavioral changes, smoking cessation, correction of nutritional deficiencies, role of aspirin is still questionable. As low-dose aspirin prophylaxis is not recommended for prevention of fetal growth restriction in the absence of risk factor for preeclampsia. This is by ACOG committee opinion in July 2018. So interventions, there is no consistent evidence that dietary modification, progesterone or calcium prevent SGA birth. Intervention to promote smoking cessation may prevent SGA birth. Medical therapy rationale is fetal growth restriction and related paraplacental pathologies are believed to arise in early pregnancy when inadequate remodeling of maternal spiral arteries lead to persistent high resistance and low flow uteroplacental circulation. The consequent placental ischemia, reperfusion injury, and oxidative stress are associated with an imbalance in angiogenic factors with anti-angiogenic factor. At present, the only management option if the risk of hypoxia, acidosis, and intrauterine death is high is iatrogenic preterm birth with the use of peripartum maternal administration of magnesium sulfate for neuroprotection and corticosteroids for lung maturity to prevent adverse neonatal outcome. The pipeline of potential therapies use different strategies, mainly aiming to increase fetal growth by improving poor placental and uterine blood flow. Ineffective in preventing FGR, bed rest and diminished activity, plasma expansion, oxygen therapy, and antihypertensive and heparin. At present, there is no effective intervention to alter the course of FGR except delivery. Labor and delivery, there are problems that is anticipated during delivery due to diminished Leica, cord compression during labor, frequency of cesarean delivery increase, and risk of neonatal hypoxia and polycythemia increase, and increased risk of motor and neurological disability. So, mode of delivery, vaginal and C-section decided. No journal accepted recommendation for mode of delivery. There is one study, over 70% of women in both study group underwent C-section, and vaginal delivery should not be attempted if poor biophysical profile to a non-reassuring fetal status prior to labor, because fetal hypoxemia may be exacerbated. In the small for gestation age fetus with normal uterine umbilical artery Doppler or with abnormal umbilical artery PI but EDV present, induction of labor can be offered, but rate of emergency cesarean section are increased and continuous fetal heart rate monitoring is recommended from the onset of uterine contraction. Growth restricted neonate should be like heads are disproportionately large for their trunks and extremities. Facial appearances has been likened to that of wizened old man, long nails, scaphoid abdomen, hypothermia, hypoglycemia, hypocalcemia, polycythemia, and compromised immune system. There is reduction in vitamin K dependent coagulation factor and thrombocytopenia. Hepatocellular dysfunction, there is low protein tolerance and higher risk of cholestasis. Long-term complications include 2.5 times greater risk of being short adult and alteration of tone, clumsiness, increased risk of cerebral palsy, lower IQI, 4 to 8 points lower than average for gestation age infant, and learning problems, behavioral and emotional problem, and there is attention deficit. Long-term morbidity include 25 to 63% of adult DM, hypertension, coronary heart disease can be attributed to low birth weight with accelerated newborn to adult weight gain. In a group of 6-year-old children with IUGR, hypertension occur in 25% of them, whereas only 16% of the control group. Oligohydramnios. Now, few words about oligohydramnios. Include inflow of amniotic fluid is fetal urine and lung fluid, and outflow fetal swallowing and intramembranous absorption. Normal Likert is 8 to 15. So, amniotic fluid makes a supportive environment for fetal growth and for fetal movement, musculoskeletal development, and protection from trauma and infection, prevents compression of placenta and cord, and protects fetuses from vascular and nutritional compromises. So, oligohydramnios incidence is 3 to 5%. Causes are severe fetal abnormality, preterm premature rupture of membrane, post-dated pregnancy, increased placental function, impaired placental function, complication of multiple pregnancies, iatrogenic and isolated oligohydramnios. Signs and symptoms are fundal height less than gestation age, decreased fetal movement, fetal heart rate tracing abnormality, and diagnosis by ultrasound, AFI 5 to 8 low normal, and AFI less than 5 or equal to less than 5 oligohydramnia. So how to measure? By amniotic fluid index equal to or less than 5, single deepest pocket. And complications are increased level of labor induction, there are chances of stillbirth, non-reassuring fetal heart rate, iatrogenic premature delivery, meconium aspiration syndrome, admission to NICU, and there are chances of neonatal death. And isolated oligohydramnios, there is no risk of perinatal morbidity. Extreme and persistent mid-trimester oligohydramnios prior to 22 to 24 weeks before the secular stage of flap development leads to pulmonary hypoplasia and perinatal mortality as high as 80%. Survivor phase may have phase with chronic pulmonary morbidities and increased risk of cord compression, joint contractures, skeletal abnormalities, and growth delay and pregnancy loss. Management depend upon POG, period of gestation, as obstetric and other obstetric complication, maternal hydration. L-arginine can be used, amnioinfusion not commonly used, we are not using this, and delivery according to the fetal and maternal factor. So, small fetuses, estimated fetal weight less than 10 should be further categorized as SGA. Fetal growth restriction, as SGA is not synonymous to fetal growth restriction. Early and late onset FGR, gestation age more than 32 weeks, represent two distinct phenotypes of the same disease with different pathophysiology and progression of Doppler changes. Integrated antepartum fetal monitoring is essential in management of FGR fetuses, and a single stage-based protocol allows optimizing decision in all cases. Thank you.